Hello, everybody, and welcome to this month's edition of the IMV Imaging Journal Club. My name's Amy, and I'm one of the vets here at IMV. And this month, I'm going to be talking you through the CT evaluation of pancreatic perfusion in 10 dogs with acute pancreatitis. So whether you've been to Journal Club before or not, we do a monthly Journal Club presentation. One of the clinical team will examine a relevant and or recent paper in the world of diagnostic imaging and break down its findings for you. So they're available to view on demand, and you can get your free half-hour CPD as a result of watching it. So what's not to love? So we love you to get involved. If you've got any questions at all, you can put them in the Q&A box, or you can send us any comments, queries, or questions to clinical@imv-imaging.com. We do really love to hear from you, so please don't hesitate to drop us a line if you want to. So the paper I'm looking at is a very recent one. It's from 2023. And as previously mentioned, it examines the CT evaluation of pancreatic perfusion in 10 dogs with acute pancreatitis, author Stade and others. So a little bit of background is always useful, and in particular, the background in human medicine is particularly important for this particular study because it's to some degree informed the study design. So we need to talk about humans and dogs. So as we all know, in dogs, the diagnosis of acute pancreatitis is difficult. You need consistent clinical signs, lab results with their own sensitivity and specificity challenges, and supportive imaging findings. In humans and dogs, if there is a delay in diagnosis, then you can end up with pancreatic necrosis, systemic inflammatory response syndrome, and a high mortality. So in humans, CT findings are strongly linked with histological findings, and with perfusion CT actually predicting the future development of severe sequelae in pancreatitis. So in dogs, as we all know, you are more likely with CT to be able to evaluate the entire pancreas and features of severe pancreatitis when compared with ultrasonography. And in dogs, the CT findings in canine pancreatitis are an enlarged pancreas, unsurprisingly, with ill-defined borders, a hyper-attenuating mesentery, just as in ultrasonography, ascites and portal vein thrombosis. Specifically, and most relevant to this study, you will also see homogeneous to heterogeneous pancreatic attenuation and enhancement. And it is specifically the heterogeneous pancreatic enhancement that we need to look at in this study. So what is heterogeneous pancreatic enhancement and why is it so important? So heterogeneous contrast enhancement in dogs with acute pancreatitis is associated with pancreatic necrosis, portal vein thrombosis, which is a very poor prognosis, a higher median spec CPL, which, as most of you will know, is IDEX's serology test for pancreatitis-specific lipase, and a longer hospitalization period, which would suggest that heterogeneous contrast enhancement is associated with more severe forms of pancreatitis. And the heterogeneous pattern is caused when there are microcirculation alterations within the pancreas parenchyma due to inflammation, which lead to hypoxia and ischemia of the pancreas, which often cannot be healed from, and then breakdown of regulation of the cells, internal mechanisms and leakage of diagnostic enzymes, etc., etc. And post-processing software with the CT scanner can calculate multiple perfusion variables, which will predict the onset of ischemia and necrosis in human medicine. So specifically in human medicine, the sensitivity is 87 to 100% and specificity 95 to 100% for perfusion CT to predict pancreatic necrosis via pancreatic ischemia, which would be an ideal level of sensitivity and specificity for us to bring forward into our canine patients, hence the reason for this study. So it's quite a broad-ranging study with quite a lot of objective and hypothesis going on. So the overall objective was to determine if there were any differences in pancreatic perfusion between healthy dogs and dogs with acute pancreatitis, to assess perfusion CT's capability for earlier detection of changes in the pancreatic microcirculation caused by the pancreatitis. So the first hypothesis is that the dogs with acute pancreatitis will have altered pancreatic perfusion variables, namely perfusion, peak enhancement index, overall blood flow, time to peak enhancement, and overall blood volume within the pancreas. And this is when compared with previously established values in healthy dogs, which was a preliminary study by this exact same group, which was quite a good strength of this study. Hypothesis 2 was that dogs with acute pancreatitis and heterogeneous enhancement, if you remember to the previous slides about how heterogeneous pancreatic enhancement occurs with necrosis, etc., they will have altered pancreatic perfusion variables when you compare them with dogs with homogeneous enhancement, which also have pancreatitis. And thirdly, a third hypothesis was that there would be an association between SPEC CPL values and pancreatic perfusion values. So, materials and methods. This was a single centre prospective case control study, which is quite nice. 10 privately owned dogs, so only 10, presented with 2 of the 3 following inclusion criteria for the study. First of all, a strong suspicion of acute pancreatitis based on the history, clinical signs and physical exam. So as you'll all be aware, we're looking for signs of lethargy, inappetence or hyporexia, vomiting, diarrhea and cranial abdominal pain. The dogs would also have to have of the following 2, because I suspect they all would have had inclusion criteria 1, having been presented to general practice. A positive SNAP CPL, which is not the SPEC test. This is a patient-side SNAP CPL, similar sensitivity and specificity to the SPEC, and ultrasonographic findings suggestive of acute pancreatitis. So we're looking for, similarly to CT findings, enlarged size and pancreatic hypoechogenicity with or without hyperechoic fat. And exclusion criteria are sonographic or cytological evidence of neoplasia. So the ultrasound scans were performed in some dogs before obviously referring on to the hospital. And whether or not FNAs were performed at that time or not could be included in cytological evidence of neoplasia. Also, there were additional tests performed in these dogs during the study to kind of rule out neoplasia. So I do wonder if there were more than 10 dogs who went through the study only then to be ruled out following all the diagnostic tests done in the referral situation. So, all dogs received an abdominal ultrasound at the hospital within 24 hours of inclusion, if not performed already, which does beg the question, is a GP first opinion level ultrasound as comparable in terms of findings for inclusion and ruling out of neoplasia and inclusion in the study as valid as that which is done in the hospital? But anyway, there was a mean time frame of 1 day from enrolment to time of CT, a range 0 to 3 days, which is fairly good. And 5 dogs of the 10 had their CT scan on the same day as enrolment, an abdominal ultrasound. So all the CT scans were performed under GA as expected, with a protocol chosen to keep the parameters as constant between the dogs as possible. So light pre-med, propofol induction, ISO O2 maintenance, plus the addition of glycopyrrolate to maintain heart rate and dopamine to maintain blood pressure. And all efforts were made to keep the heart rate and blood pressure within a similar range to the patients in the initial pilot study. Now, there was no comment on this, but I do think this probably would have been quite challenging, given the pilot study patients were well, and some of these pancreatitis patients were very unwell, meaning their GA would have been very difficult to maintain as stable and as comparable with the other patients. So an interesting area there. So for the CT, they used the same 16-slice scanner as they used in the pilot study, which is a good continuation. An initial pre-contrast full abdominal CT was performed to find the pancreas, and then a 24mm section of cranial abdomen, which included pancreas, I suspect most likely the body of the pancreas, was selected. Power injector was used to deliver contrast at a standard dose and rate. A dynamic scan was performed every 2 seconds for 1 minute over the chosen area, and mechanical ventilation with breath holding was used for the dynamic section of CT. And after the contrast section, a post-contrast full abdominal CT was performed. There was no comment about whether they were searching for abdominal neoplasia at this point. Given that the exclusion criteria only listed sonographic evidence of neoplasia, I'm not actually entirely sure. The attenuation of the pancreas was evaluated by visual evaluation and Hounsfield units. Thirdly, contrast enhancement of the pancreas and its regions was characterized as absent, heterogeneous, or homogeneous. So the heterogeneous versus homogeneous component of enhancement is what we're really looking out for in this study. Under the same GA, the pancreas was evaluated with abdominal ultrasound, AUS, to obtain an FNA, or a fine needle aspirate. And this was to support, if possible, the clinical and imaging evidence of acute pancreatitis, given histology or histopathology is really the gold standard for diagnosis of pancreatitis, as difficult as it can be to obtain. This was not performed if it was unsafe, and unsafe in this case was pancreas not ultrasonographically identifiable, or if small intestine were overlying the pancreas with no clear path for aspiration, or if there were coagulation abnormalities, or the patient was on an anticoagulant. And indeed, one of the dogs was on quite an impressive collection of anticoagulants. And the right limb was aspirated when aspirated, it being the most accessible. And then pancreatic and peripancreatic changes were recorded, and this was on ultrasound and on CT, just because, while we're there, we may as well catalogue the evidence that we are seeing to help to inform the literature. So a comment on regions of interest. So it would be great if we could ask the CT software to highlight the pancreas and calculate perfusion variables across the whole region. Now, unfortunately, that is not possible. So regions of interest are placed on the pancreas, chosen by humans. So in this case, the examiners who were very experienced radiologists and a resident in diagnostic imaging. So placed on the pancreas for collection of perfusion data and then subsequent generation of perfusion maps. And I'll show you some perfusion maps in the next slide. So the first ROI was placed on the aorta for reference, plenty of perfusion there. And then there were 2 ROIs placed on the body of the pancreas. So they were ovoid in shape and similarly sized to the pilot study. And they avoided blood vessels and the pancreatic border. So if, in the case of heterogeneous pancreatic enhancement, the ROIs were placed in different regions of enhancement. So they weren't placed in only hyper-enhancing or hypo-enhancing areas. There was one placed in each. So the perfusion variables which were to be calculated, and this was stated in the hypothesis, are perfusion, the peak enhancement index, the time to peak enhancement, and the blood volume within the body of the pancreas in these dogs with acute pancreatitis. So just for interest's sake, this is a selection of images from the paper. So what you're looking at here is the same slice in the same dog, transverse CT images of the cranial abdominal region in a dog with acute pancreatitis and heterogeneous pancreatic enhancement. So you can see where they have placed the ROIs in image A. We have a cross in the aorta, which is marked with artery. And then we have a heterogeneously enhancing pancreas, which is pointed out by T1 and T2, the two ROIs. So if you weren't sure where the pancreas was, and I don't blame you, that's where it is. So you'll notice that T1 and T2 are placed on differently enhancing regions of the pancreas. So the colour maps show the lowest scale is blue up to the highest in red in terms of amount of perfusion. So image B shows overall perfusion of the ROIs, and image C shows the enhancement index, image D shows the time to peak enhancement, and image E shows the blood volume. So that's just a little bit of interest, for the sake of interest, to show you what that actually looks like in post-processing. Okay, results time. So what did they find? In terms of signalment, 10 dogs made the inclusion criteria, 9 neutered, 1 female entire, median age 9 years, median weight 29.2 kg with a considerable range. So generally speaking, pancreatitis would be expected in the older dogs, but smaller. So that's quite an interesting range they have there, although only 10 animals. So not overall indicative of a large population of dogs. All dogs had clinical signs of acute pancreatitis, and 6 of them had a SNAP test done. All were positive, and 10 of them had a SPEC CPL done. I suspect some at the primary care, some at the secondary care. 5 were normal, 2 were equivocal, and only 3 were increased. That's quite interesting. So to explain what happened there, the prevalence in the population of 10 dogs in this paper was high. So high sensitivity of a test helps to exclude a diagnosis of pancreatitis in this case in the absence of disease when the prevalence in the population is low, i.e. high sensitivity means the chances are that your negatives are negative. So with prevalence being high in this population, it shows you exactly what happens with test results in that situation. So that's quite interesting. So these results are the ultrasonography, FNA, and start of the CT results. So graph on the left, the pattern in these graphs is that each bar represents the 10 dogs. The paler bar represents those for the finding being positive, and the darker bar represents the findings for the dogs being negative. So AUS, or abdominal ultrasound, findings positive for pancreatitis, 6 out of the 10 dogs. Gastrointestinal thickening and ileus was found in 2 of the 10 dogs. That's the next bar over. In the next bar over, we have only 5 of the 10 dogs having an FNA performed. And of the results, we had 2 which were positive and 1 which was negative out of the 5. The missing 2 dogs from that bar were non-diagnostic. So that just goes to demonstrate how difficult definitively diagnosing pancreatitis is. So CT results for pancreatic size: 10 out of 10 dogs have pancreatic enlargement, 7 out of 10 it's in the right lobe, 7 out of 10 it's in the left lobe, and 9 out of 10 it's in the body. So it's quite good to see some kind of patterns there that are reliable across, more than just a handful of the dogs. But it also may be that with the body of the pancreas being the area where the window was concentrated for the scan, whether the body was actually just more reliably seen or imaged with that small window. So in terms of pancreatic attenuation and enhancement on CT, in 7 of the 10 dogs, the entire pancreas was homogeneously attenuating, so a darker than normal on scan. But in 3 of the 10 dogs, there was a regional hypoattenuation. So interestingly, within those 3 dogs where there was only regional hypoattenuation, there was 1 each of right limb affected, left limb affected, and body. Again, if you were performing ultrasound to try and diagnose this sort of change, you could well miss it, particularly with the more challenging left limb and body area. So with 7 out of the 10 dogs on contrastly enhanced scan, there was homogeneous enhancement, meaning that only 3 of the dogs had the more severe pattern of heterogeneous contrast enhancement. And last graph, just out of interest, peripancreatic findings on CT. So I think these are obviously easier to find on CT than they are on ultrasound. So we had abdominal lymphadenopathy only in 2 out of 9 cases. There is a 10th dog missing here because the dog had diffusely unidentifiable lymph nodes, which were sort of mottled and difficult to pick out. So there was either something, a pathogenic process going on there or some unknown process. So only 2 out of the 7, which is surprising, I suppose, and each dog had a different set of lymph nodes affected. In 2 out of the 10, there was portal vein thrombosis, which you'll remember from earlier on in the presentation is associated with a poor prognosis. In 3 of the 10 dogs, we've got extrahepatic biliary obstruction, and in 4 of the 10, we have mineralized gallbladder sludge plus or minus cololiths. And in 6 of the 10 dogs, we've got gastric and duodenal distension, which is, to be expected and hopefully would have been a bit more detectable on ultrasonography, but apparently not so with the ultrasonography results. Again, there's no comment as to whether the ultrasonography results were directly from the referral centre or from primary care. And in 3 of the 10 patients, there was gastric and small intestinal wall thickening. 9 out of 10 showed fat stranding, and 3 out of 10 showed peritoneal effusion. So other miscellaneous findings was an acquired liver shunt in the dog with extensive portal thrombus. There was pancreatic edema, a peripancreatic cyst, and a liver infarct. So acute pancreatitis really can cause an awful lot of abdominal issues. Okay, so in this table, we are examining the perfusion variables calculated with the post-processing software, which were those colourful pictures I showed you. And we're assessing them in the healthy dogs from the pilot study versus these dogs with pancreatitis. And the pancreatitis group include all 10 dogs in this particular table. And the n equals 12 for healthy and n equals 20 for pancreatitis is a bit confusing, but that's because in the prelim study there were 6 dogs, but 2 ROIs for each dog, so 12 measurements. In the pancreatitis study, there were 10 dogs with 2 ROIs for the pancreas, so 20 measurements. But as you'll see, there are big differences between perfusion in the healthy dogs and the pancreatitis dogs, but it did not reach significance, which is surprising given the big difference. Peak enhancement, not much change. Blood volume at the bottom, some difference, but not statistically significant. But the time to peak enhancement did reach statistical significance. So in dogs with pancreatitis, the time to peak enhancement is lower. So there's a faster inflamed blood supply to a pancreatitis pancreas, which makes sense. In this table, we are comparing the same perfusion variables as the last slide between the homogeneously enhancing dogs with pancreatitis and the heterogeneously enhancing dogs with pancreatitis. So you'll see here that we've reached statistical significance in more cases here. So with perfusion, much less perfusion in a heterogeneous pancreas with pancreatitis. Peak enhancement index is a bit of difference, but not statistically significant. So it enhances less as expected. There's less blood supplied to this damaged necrotic pancreas. The time to peak enhancement in heterogeneous cases is higher. It's taking longer for the blood to get into the pancreas because there's so much microvascular damage. And the blood volume in a homogeneous pancreas is very much higher than a heterogeneous pancreas. So the heterogeneous pattern is showing that there's much, much, much less blood supply because there's been such a great amount of damage. So that's quite interesting. So our hypotheses, hypothesis 1, if you'll remember from the beginning, has been partially accepted. The only perfusion variable which was shown to have statistical significance between pancreatitis dogs and normal dogs was the time to peak enhancement, despite the fact that overall blood flow was very much higher in the pancreatitis group. So partially accepted. Hypothesis 2 was completely accepted. So dogs with pancreatitis and heterogeneous enhancement have altered pancreatic perfusion parameters compared with dogs with pancreatitis and homogeneous enhancement. Hypothesis 3 was rejected. There was no association at all between SPEC-CPL levels and pancreatic perfusion variables, which I didn't include in the results, but it's easy enough to state it here in the hypothesis. So disappointingly, SPEC-PL not correlated with pancreatic perfusion. So to discuss the results, in this study, all the pancreatitis dogs, the 10, were compared to normal dogs for perfusion values. However, if they only compared the homogeneous enhancement dogs with normal dogs, the pancreatic perfusion variables were much higher with pancreatitis dogs, and they were all statistically significant, which is very useful. So that can be taken forward. The heterogeneously enhancing dogs obviously had lower perfusion variables. Added into the homogeneous enhancement variables group will have brought the perfusion variables down and reduced the chance of significance. If there were more dogs in the study, perhaps significance would have been reached regardless. The study demonstrates a very similar pattern to that used in human medicine for this diagnostic tool. The sensitivity and specificity of diagnosing necrotizing acute pancreatitis are as high as 100% and 95.3%, respectively. So potentially no false negatives in human medicine, which is incredibly useful. So if this is going to be carried forward in dogs, that can only be good news. So the heterogeneous enhancement in acute pancreatitis dogs, just the 3 of those dogs, when analysed against normal dogs, had similar perfusion values as a normal pancreas. So the question is this due to the placement of the 2 regions of interest by the examiners? So in this study, as you'll remember from before, there was an ROI placed in a hyper-enhancing and one in a hypo-enhancing area, which likely enhanced the overall blood flow, rather than if the ROIs had been placed only on hypo-enhancing areas. So another factor is that determining that small 24 mm window of pancreas to scan may have also excluded larger hypoenhancing regions. So future studies may actually focus on the evaluation of only the hypoenhancing regions of severe acute pancreatitis, which may actually increase the predictive value of this technology. There was no comment in the discussion section on whether the human diagnostic algorithm and research has been based on placing ROIs only in hypoenhancing regions. So that would have been quite useful to know. So this study definitely reiterated the challenges of diagnosing acute pancreatitis in dogs. So the SNAP CPL, the patient side, sensitivity is 74 to 100% reported. Specificity, not great, 60 to 78%. And compared with the SPEC CPL, the lab test on serology, 70 to 94% sensitivity, and the specificity, again, not great, 66 to 88%. And those were figures reported within the actual paper. So combining that with the fact that pancreatitis was present in all the dogs based on the diagnostics, and all the difficulties with observing which limb of the pancreas was affected, and the challenges with aspirating the pancreas, etc. It is very difficult to diagnose, so it does add weight to the importance of these sorts of findings, the outcome of this paper. So as previously mentioned, with all of the patients in this particular study having pancreatitis, that contributed to the decreased sensitivity of SPEC CPL in the study. So further work, limitations first. Two of the patients actually had repeated CT, and this was due to peripheral catheter placement issues and a subsequent deficit of contrast. So in the pilot study, with the well dogs, all the dogs had an 18-gauge cephalic cannula, which is quite a meaty catheter, allowing the volume and velocity of the contrast to be injected. But with this study, obviously some of the patients were very unwell, which may have had a very low sort of systemic blood pressure and therefore difficulties in cannulation. The authors did say they didn't think that two back-to-back contrast-enhanced CTs would have affected the results. There was obviously some variation in the hospital medications and drugs given between the patients, and therefore was there an alteration in pancreatic perfusion between the patients, particularly with the GA drugs? Potentially. Using a 16-slice CT scanner may have limited the portion of pancreas evaluated, and there were only 10 dogs in the study, so no power analysis was possible. Which leads us on to discussing further work. So to repeat the study and make it larger, although this is difficult, with a different CT manufacturer perfusion software to actually assess the reproducibility of these results across different CT manufacturers. Secondly, it would be great to establish a baseline or cutoff value of perfusion to detect pancreatic ischemia. That would be pretty handy. And thirdly, to compare perfusion values to outcome, as with human medicine, and to find out if there is a predictive value. So that's it. Thank you for listening. As I said at the start, if you've got any questions at all, then please get in touch on clinical@imv-imaging.com, and we'll get back to you very quickly, and we love to hear from you. So thanks for listening, and we'll catch you at next month's Journal Club.